a lot like the knee. Volunteer patient.
No one wants to know what to do with it.
So similar to the knee exam, my number one take homes always are do the same exam every time, no matter what the person says, and then do it in the same order every time, no matter what. That's like my take home point over and over and over again with the exam, so you don't miss things. And it's always inspection, palpation, range of motion, strength, neurovasc, special tests. That's the way I do it every time, no matter what. That way I never miss anything or forget to do something important, forget to document something, etc. So shoulder exam compared to knee exam. Shoulder exam is easier to do, but less helpful. So none of the shoulder exam stuff is very specific or very sensitive per se, especially in an acute injury setting where everything tends to hurt. So even the shoulder, the history part of it plays a very big role in helping me kind of decide what's going on, what do I need to do, etc. So even more so than the knee, like getting a really good history, trying to like find out, was there like instability that they felt? Is this like, was it a trauma? Was this like a slow gradual buildup? You know, what kind of activities are they doing that might put stress on the shoulder? You know, even just looking at their posture, how they're sitting, that might put them at like risk of having problems, things like that. So I'm definitely diving in a little bit deeper on history when it comes to a shoulder, so that I have a better idea of what I'm looking for and can make a little bit more sense of the exam as I go through. So exam-wise, so starting with inspection, again, like I said, first thing I'm always looking at is just how they're sitting. Nowadays, you know, everybody's on their computer phones, so they're hunched over and everything like that, which can influence shoulder, neck pain, like the upper back shoulder area is becoming like the new low back because of how everybody sits. In the sports medicine world, those visits are catching up quickly to low back visits. So the prevalence of it has become much more over like the last 5-10 years. So inspection, watching how they're sitting at the table, like looking for their posture, looking at shoulder heights, are they drooping one, anything like that. Then when I actually go to examine, so if they're sitting in front of me, let's have you turn like this. So I'll look from the side, I'll look at their back, so ideally in a gown, so you can see shoulder blades, how are they positioned, do they look symmetrical, looking across the front, looking at AC joints, making sure there's no step-offs or anything or deformities that you can see. Acutely, making sure that the shoulder looks like it's not dislocated, anything like that, if there's any abnormal lumps, bumps, things like that. So one thing about the shoulder compared to the knee, you can see muscle spasms themselves. So you can see like around the shoulder blade, things like that. Sometimes those muscles are just balled up tight. So you can get decent information right off the bat just by looking. So inspection. Palpation. I always kind of same thing as knees. I start for me on this one, I start in the back and make my way around to the front. You could start at the front and come right around to the back, either way, but I do it systematically, just like the knee. I start at the top, make my way down, shoulder, start at the back, make my way around the front. I like to do that just because I do see more trauma and like acute stuff, so I start with the back because I start with the neck. So I'll start on the cervical spine, coming down, feeling along the spinous process, make sure they don't have any pain there or anything before I start doing anything else to them. And I come down to like the mid to lower part of the thoracic spine, just kind of go past below the shoulder blade. So I come down the neck, make sure they don't have any central like midline tenderness or anything like that. If that's all okay, then I can cruise on through the rest of my stuff without having to worry. So then I go into paraspinals, going into around the shoulder blade and around, see if any of that's tender, coming across the top through the trap, across like the supraspinatus, infraspinatus areas, coming around to proximal humerus, So rotator cuff attachments, anterior, so the bicipital groove, and I'll usually roll over the bicep tendon, see if that's tender, and then coming across, so bony stuff, AC joint, coming across clavicle to SC joint. So again, you can come the other way around too. I just tend to, that's my habit, and so again, I do it the same every time. So inspection, palpation, range of motion. So I usually just stand in front and have them copy my movements. So starting your sides, come straight up to the front as high as you can, straight back down, straight to the side, straight back down, coming here, rotating out, and then sliding up the back as far as you can, and just comparing side to side. If it's hurting, asking when it hurts, etc. I always start with active range of motion, and then if they can't do something, then I go to passive range of motion. So if they come here or here and say, oh, I just can't do it, or it hurts too bad, or it feels like I can't, then I'll do passive range of motion and make sure I can actually move them up past, looking for frozen shoulder. So if it's just pain and I can get them past, then I don't have to worry about that. And frozen shoulder is not the most common in our age group, but we do have older students who are, especially like 40s to 50 women, super common frozen shoulder. So if they feel stuck and you can't move them past, and it's not just muscle, then you start thinking about frozen shoulder, things like that. So, and then again, range of motion stuff, if everything's over shoulder height, you start thinking like rotator cuff, impingement. So as I'm going through, I'm starting to kind of get my differential in my mind as we kind of go through. So range of motion, strength, I'll have them come here. I'll help them get there if it's hard for them. So help them up and just hold. And I'll bring them out. So checking like deltoids, checking supraspinatus. Good. Now come here and relax down. Hold, don't let me push in. And then push in against me. So I keep it pretty basic, rapid fire, making sure that there's no significant weakness. So rotator cuff tear, they're going to be like have no resistance essentially. So not super common in young healthy age group again. See it definitely more in middle age, acute injury, stuff like that. But it's one of the things you don't want to miss because that is something that needs surgery sooner rather than later. So if they can't hold at all, they're dropping, they can't push out at all, that's something that's going to worry me and like help influence my decision when it comes to what my plan is going to be. So strength testing, neurovasc. So looking if concerning for shoulder dislocations can injure some of the nerves, things like that. Try to pinpoint like could this be cervical, things like that. So I always do like a quick and dirty neurovasc test. So I'll usually have people spread their fingers, don't let me pull in, hold your fingers straight in a 4 sign, go like this, don't pull through, perfect. Does it feel the same both sides? And then instability stuff, looking for axillary nerve distribution, which is one of the most common dinged nerves when they do dislocate. So if that's all of a sudden feels different than the other side, that helps influence me, hey, that might have been an instability episode, and again, help me form my differential as we go. Now, special tests. So special tests for a shoulder, not very good. So I do kind of like the same 6, 7 every time. And it tends to hurt with a lot of them. And then I try to put the information together based on, how much each one is hurting and their history. So when I do my special tests, I have like a sequence I do that try to make it as quick as possible so I can kind of rapid fire through everything. So when I start, I try to get them to relax. And so I'll start by just holding their wrist and start with impingement testing. So near to the ear. So you rotate hand in and come up to ear. And I usually like help support their shoulder here, keep them relaxed. So near test is near to the ear. And while holding the wrist, I will switch to Hawkins. So Hawkins, Burt, flapping. So Hawkins, another impingement test, looking for pain there. Still holding the wrist, cross body abduction or adduction, looking for AC joint. And then I'll go to O'Brien's, which is a stability test. I'll go through this again. So I'm just going to demonstrate what I do. But O'Brien's, so thumb down, hold strong. Thumb up, hold strong. Positive test is more pain with thumb down. Then I'll again relax. Come here, hold strong. So speed test is looking for bicep tendon. Good. Now have them come down, relax, go to the arm to the side, do palm towards the ground, and then just, this is Jurgensen's test. So it's rotating, you start with palm down, and then you rotate palm up, while externally rotating and flexing arm. It's kind of this motion. So it's look for, again, bicep tendon. So you resist, so you're gonna pull up and go like this, and then I'm just gonna resist it. So, and then at the end, I will do apprehension. So I have them lay down on the table and look for anterior apprehension. So that is my rapid fire through special test. So I essentially grab their wrist and can do all of it, boom, 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 without hardly ever letting go. And so I can get through it in, 30 seconds to a minute, which is practice. But that's why I like doing the order of it that I do, is because I just can kind of get, essentially they're just sitting on the table, and I can just kind of rapid fire through it and get information. So why do I do it that way? So I do, essentially I'm doing 2 tests for each kind of thing. So I'm doing 2 impingement tests to see, are they both hurting, are they like both similar kind of pain, provocation when I'm doing that. I'm doing 2 stability tests between O'Brien's and apprehension. I'm doing a couple bicep tendon tests, and then the 1 AC joint, because there's really just 1 AC joint test. So I do a couple tests from each thing, and then I use that to kind of, again, help decide what is going on. So from like a primary care, that kind of is both for both primary care and urgent care setting. Urgent care, I might do a few more tests when it comes to like looking for stability things, like doing some other stability tests to look for like posterior instability or things like that. But for the most part, you guys don't have to worry about that. That's just because I'm sports medicine and I get curious, so I'm usually going to be seeing them again anyway, so I just get it all done at one point there. But for you guys, that should cover pretty much anything you need. So then if you just get good at those tests and relatively comfortable with the findings and things, you should be pretty much set. The biggest thing for you guys then is deciding what we need to do. How do I use these tests to like make a plan and things like that? So for most shoulder stuff, initial treatment's going to be physical therapy. They had an instability episode, first time instability episode, things like that, physical therapy. If you're looking, deciding on imaging, the 3 things I kind of look for. If they had a major instability episode, I always x-ray, make sure that there's nothing there. If they had a trauma, or then like a significant trauma, I almost always image. And then any deformity or bony tenderness on palpation. So like the AC joint stuff, like things like that. If it's more for a primary care setting, I rarely image initially if it's a more chronic pain with just overhead, things like that. I'll usually start with treatment, and then if they're not improving like I'd expect, then I start thinking about imaging and things. I rarely order an MRI off my first visit unless it's rotator cuff concern. Otherwise, I almost always start with rehab, and then if not improving like I'd expect, then I go to an MRI. Or if they have like a weird, like neuro, like fast, like lots of like numbness, things like that, that might make me more inclined. But otherwise, it's almost always for shoulder stuff is starting with rehab and then kind of going from there. So I'm going to go through special tests one more time, a little bit slower, because that's the big part that's hard to remember. So special tests. I do the 7 tests. I hold wrist. So I kind of just grab a hold, have them relax, get them loosened up just a little bit, and then rotate, so near to the ear, slowly coming up. Positive test is pain, especially as you get to the top, because you're just kind of impinging down on that rotator cuff. Then kind of reset, and then I kind of moved my hand a little bit further up the arm with like my pinky, so I have a little bit better control. And then we're coming across and just rotating down. So again, if you need to move your hand down a little bit to help you, you can. I usually are able to control them enough. And then you can kind of make your way across the body. The further you go over, the more you're cramping down on that rotator cuff. So if that's getting gradually more painful as I go across, that starts making me think, again, this could be impingement that's going on. So again, hand, same place. Now we can come across for cross-body adduction. This is AC joint test. So AC joint, coming across clavicle. So you're looking for pain at the AC joint. So right in here where my hand's still kind of sitting. And I will really smash it across. So, and then, so next one, O'Brien's. So you're already kind of over here, reset just a little bit. So O'Brien's, about shoulder height. You want to internally rotate a little bit further and then turn your thumb down. So this is looking for like slap instability, which is anterior and superior labral injuries. So throwing athletes, things like that. So thumb down, hold, and then I flip thumb up, hold. Equally painful is not a positive test. So positive test is more pain with thumb down than thumb up. Again, they're not super sensitive or specific, but generally that's what I'm looking for, is more pain with thumb down. Then again, reset a little bit, straight out, hold. So speed, looking for bicep tendon, holding. So shoulder height, palm up, good. Reset, and come to the side. So shake my hand, and then do this motion. So rotate out, flex. So this one's harder to get people to do, but so it's rotating out, rotating hand up, so and flexing your arm. So it's kind of like that. So come back and reset. Yeah, this is another bicep tendon. So start here, now rotate up, out, and there you go. And so I'll usually try to put my hand on the bicep tendon as well to help feel it. And then last one, I have them lay down on the table and then do apprehension. So if they had, that's usually not a fun test if you've had instability, so I wait to the end to really push on that. So questions? One of them you want me to show you again before we do breakout, or do you want me to run through the whole thing again before we do breakout?
Do you have any mnemonic devices to remember the names of your tests and what they're testing for? Besides year to year.
I have, I guess I have my smart, I do it so often, and I have my smart phrase that I just automatically populate my exam that has all the exam stuff in it. But I do not have a good mnemonic, because I just kind of do my own order. Like other people do different orders and things, but I like how I do it just because I can do it fast, because I'm just holding onto the wrist the whole time and can kind of cruise through it.
Do you have like a text macro that you use?
Yeah.
Will you share with us?
Yeah, I can do that. So same thing with the knee. I have all that stuff like written down and documented in the same thing, like the inspection, palpation, range of motion, strength, neurovasc, special tests. So it's all documented that way too. So when I blow it in, it's easy to just kind of rapid fire through. So
Neck and spurlings, how often do
I-
you do that, and how reliable do you find it?
It's not super. So again, that's like getting history and things. Like if it seems like they're having ridiculous like pain into their arm or like something that just seems weird to me, I'll add that in and I'll maybe do like cervical range of motion and like more tests like that. Like trauma stuff, I'm gonna do more cervical things like in a primary care setting. I more just look for, are they having like weird symptoms down into their arms and things. For like a chronic neck thing, again, initial treatment is PT, or PTs are very helpful. And so as long as it's not like an acute finding thing, you're probably gonna start with PT anyway, and then if they start picking up some stuff too, then you kind of work together. I'm thinking, hey, maybe we need to like focus our exam a little bit more on that. So in the primary care, it's going to be pretty unlikely you're going to have an acute cervical thing walking in. So, but yeah, so I don't do it every time. Other questions?
If someone has just reported like subluxation or dislocation of the shoulder, are there things you shouldn't do so as not to
I do pretty much everything still.
Okay.
I just do it slowly. And so, like, as I'm doing a lot of that stuff, I have my hand on the shoulder. So I'm there to, like, stabilize. If you go slow, you're not just going to pop them back out. You're going to be limited, though. But, so sometimes, like, special tests, like, if I just reduce them, or, like, they have an x-ray showing dislocation, so you already know the diagnosis. I might not do all the special tests, but I would go all the way through the neurovasc part, and then you can limit the special tests if you like have an x-ray confirmation that's what's happened,
Yeah.
etc. So, other question? Ready to do hands-on, or you need me to go through one more time?
Do it one more time.
One more time. Okay. So I'll kind of go through everything. So, inspection. So again, looking at posture, looking at neck, back, muscles around the shoulder, looking at bony stuff, so looking at AC joint, clavicle, shoulder, make sure everything looks appropriate, no deformities, anything like that. Palpation, starting neck, going down cervical spine, looking midline tenderness, going down thoracic spine, going around shoulder blade, paraspinal muscles, trap, the muscles around the shoulder blade, the supraspinatus, infraspinatus, proximal humerus, so rotator cuff attachments, bicep tendon, and I usually you can feel when you roll over it with bicep tendon. And then coming across to like AC joint, acromion, coming across clavicle, SC joint. Range of motion, so that's inspection, palpation, range of motion. Come straight up, straight down, straight to the side, all the way up, all the way down. Externally rotate out, as far as you can. Yeah, limit it on one side, and then sliding up your back as far as you can. Okay, and then asking, does any of this hurt, etc., looking for subtle abnormalities. Come here, hold strong. Good, relax into my hands. Here, hold strong. Good, relax down like this. Don't let me push in. Push it against me. Good, perfect. So you feel the touching. Good, feel the same both sides. So neurovasc now. Hand out like this. Don't pull your fingers in. Keep your fingers straight. Go like this. Don't pull through. Perfect. And now special tests. So relax into my hand. Come up. Good.
Can you say the name of the
Near to the ear. Sorry, yeah. Near to the ear. So holding again. Rotate up near to the ear. So Near's test. And then relax. So Hawkins, so like bird, hawk. So good. Hawkins, crossbody adduction, no fancy name. So crossbody adduction, good. Relax. O'Brien, so stability test. Come here, so slightly internally rotated, thumb towards the ground, hold strong. Put thumb up towards the ceiling, hold strong. Positive, if more pain, thumb down. Relax. Speeds, looking for bicep tendon, just straight out, palm towards the ceiling, hold. Good. Relax. Yergeson's, so palm towards the ground, shake my hand, and rotate up and out. Perfect. Just like that, and then lay down apprehension. If you want me to show apprehension, I haven't actually shown. Go ahead, lay on your back for me. So apprehension is they're laying on the table, and I put their body right to the edge of the table, and it's literally just bring arm up like this. So if they have anterior instability, which is where a majority of dislocations are, they are not going to want you to put your arm up there. So positive test to me, I will help stabilize their shoulder, especially if I'm really worried about dislocation. I'll have my hand there right away and kind of make my way up and see how they do, and then I'll kind of gently lift my hand off, and if they're like not happy with me, that's a positive test. So that's it. So I can rapid fire through my whole exam pretty fast once you get like in the habit routine of it. So yeah.
I don't know if you do this, but one thing I find super helpful when I'm doing the neurovascular exam, especially at the hands, is to do both hands at once.
Yeah.
Because I find that when I'm doing one hand, people tend to be a little bit more cautious. It's much harder to do that if you're actually testing both hands.
Yeah, I usually do, like, all that strength stuff I usually do both sides, yeah. So it goes relatively quickly. Okay, other questions? So and then the big thing with this, a lot of these tests are, as long as you get in the habit of doing the same thing every time, these tests are a lot easier to do than like a knee exam, trying to do a Lockman or a McMurray test and like trying to make sense of that. But the hard part of the shoulder is they're just not great. So the literature on how good these tests are not very good. So that's why I do like this whole combination of things, and I try to put the picture together. The big things in primary care that you do not want to miss: fractures, rotator cuff tears. Those are two things that are going to need like immediate treatment. Rotator cuff needs to be repaired in a certain amount of time for really good outcomes, and fractures are going to need different care than the other stuff. But a lot of shoulder stuff in our age group ends up like, so impingement, even instability, all of that kind of stuff, muscle spasms, all of that really starts with like physical therapy anyway. So as long as you get a good general idea, you rule out the big bad things, like physical therapy is going to be a pretty safe starting point. And our physical therapists are very good about getting them down to me if they all of a sudden notice something else. And they're like, hey, I think we need to look at this a little closer. So.
And you were saying, in terms of the rotator cuff test, really determining the decision point is whether they have weakness.
Yes. So
Because
pain.
They can have pain.
Yep. I don't worry too much
everything,
about
but they have
pain. They're
weakness.
probably going to hurt. Like almost all shoulder stuff, they're going to hurt with one of the rotator cuff tests. Like if they dislocated it, they sublux, if they have impingement, if like just any chronic instability, like all of that puts a strain on the rotator cuff. So I very rarely do a shoulder exam where it doesn't hurt. I'm looking for frank weakness to decide, like, do they have a tear? Because even if they have like just a partial tear, you're not going to do anything for that aside from rehabbing it initially anyway.
So when you say tear, you're talking about a
full thickness tear. That's what you need to make sure they don't have. So, but yeah, I use it a little bit putting pieces together, but I usually just expect that it's going to hurt when I'm doing my strength testing. I tend to test them till they break, always. So, so by the time, so they're usually like going to hurt by the time I do that. So,
What is the window for the rotator cuff repair?
like I usually shoot for like 6 within. You can go out further. The longer it goes, the more it retracts, and the harder it is to stretch it back out to like repair it. So yeah, our population, again, a little bit easier. They tend to do a little bit better. You have a little bit more leeway and things like that. But I order an MRI right off the bat if there's rotator cuff worries. So, and for us, we usually get our MRIs within a few weeks. And then our surgeons can get them in very quickly. Like you don't have to like, I don't even necessarily do an urgent MRI, but I do get one ordered right off the bat and then follow up and make sure they actually get it. Other questions?
I have a question. In terms of history of injury, as far as increasing your worry for rotator cuff, tear, what kind of things have you seen?
So like doing acute injury, so like a dislocation, things like that, you can get a rotator cuff tear. Like doing like a strenuous physical activity, like feeling a pop and then being like, I just can't move my arm, things like that. Or when they're like, if they're really doing range of motion, if you're seeing them like really hike to get their arm up even a little bit. So trying to use their trap and things instead, or delt rather than the rotator cuff to like lift their arm. Those are the big things. Acute injury with a dislocation and not being able to move arm. So dislocation gets a little tricky because sometimes they don't want to move it at all. But that's where I help them get to the position and they just need to do some resistance. I'm not looking for 5 out of 5 strength. I'm looking for them just to be able to hold that position against like gravity and a little bit of force, and then I'm content that they don't have a full tear. So, anything else? Okay, hands on. So, partner up and let's cruise through some hands-on stuff, and then I can help with questions and things.